Hi, good afternoon, everybody. We're going to get started with our AvaSure webinar today, so welcome and thank you for joining. Couple of housekeeping items as we get started. The attendees are all going to be muted throughout the whole presentation. This presentation is being recorded and there will be a copy available and sent out to the attendee list for your listening and sharing later on. At the end, there's going to definitely be a Q&A session. So if you have questions that aren't being answered during the presentation, go ahead and type them into the question box and we will get to those questions toward the end. Any questions that are not answered that you do type into the box, we will follow up with an email. So again, thank you for joining. My name is Stacy Overholt. I'm a nurse and I am the Director of Clinical Sales at AvaSure. I've been with AvaSure since I think 2013, and I do have a background in multiple nursing disciplines, my favorite one being pediatric inpatient and outpatient care. So I'm honored today to be the moderator for this discussion as we talk about the importance and the growing need for safety monitoring of our young patients. I know that hospitals are definitely seeing increased census across the country in pediatric EDs and in inpatient units. They're filling up with kids with major mental health illnesses and increased suicidality. I think especially recently, it's probably likely due to the impact the pandemic has had on mental health across the board, and especially in children. One of the articles, as I was getting and preparing for this webinar, one of the articles I recently read has reported about 1 in 10 hospitalized children have both a medical and psychiatric illness. And these will typically result in the additional need for safety resources while under our care. I know in the hospitals, especially when I was working in the hospitals years and years ago, it's common to use trained safety attendants to provide this additional level of safety. One-to-one sitters are what they're traditionally called at the bedside to keep these patients safe. Literature, however, continues to show inconsistencies in the outcomes of this model, and most hospitals can't manage the cost or keep up with the staff that's needed to support this. We've seen at AvaSure over the past few years an increase in the use of technology and our technology to assist with important safety measures in this population too, in the pediatric population. I know Joint Commission and some of the other regulatory bodies still mandate safety attendants for certain types of patients, especially in the high-risk suicidality area. But video monitoring for fall prevention, staff safety, adverse event prevention, and low to moderate risk suicidality can and should be used to improve outcomes and lower costs. Our telesitter solution has been helping people keep people safe since 2009. I still can't believe it when I say that. And we've grown into the leader in video monitoring technology. I just want to share with you a little bit about what we see in the pediatric world today. We provide a technology platform with advanced clinical programming and guidance for nearly 1,000 hospitals across the country. But our program data shows that over the last 3 years alone, more than 4,000 pediatric patients that are housed in pediatric hospitals, pediatric units, pediatric EDs, and even non-specialty EDs have been placed under video surveillance successfully. 57% of these pediatric patients, according to our data, are placed on video monitoring when they present with low to moderate risk suicide ideation. The other 43% are placed on video monitoring for the prevention of elopement, falls, intentional self-harm, medical device interference, and staff injury, prevention all combined. So our panelists today are eager to share information about their programs and how they have implemented video monitoring to keep their young patients safe. Today, we're going to meet and talk to 3 nurses from 2 different hospitals. We have Jamie Clendenin and Melanie Lee from Anne Arundel Medical Center, part of Luminous Health in Annapolis, Maryland. We also have Ashley Nursky from Helen DeVos Children's Hospital, part of Spectrum Health in Grand Rapids, Michigan. Ashley's picture is not showing. There was a little bit of technical difficulty, so we are trying to include her at least by phone. Are you there, Ashley?
Can you hear me?
Yes, we can hear you. Great.
Okay.
So we'll be able to still talk with Ashley. Unfortunately, you won't be able to see her face, but she is with us, and so we'll be addressing some of the questions to her too. So here we go. All right, I'm going to ask the first question and give you three an opportunity to introduce yourselves, share with us what your role is with the AvaSure Telesitter program at your hospital, and how long you've been involved. Let's start out with Melanie on this.
Hi, good afternoon. I'm Melanie Lee. I'm the clinical director for the Pediatric Emergency Department and Inpatient Unit at Luminous Health Anne Arundel Medical Center. I have been involved since the very start, since we started doing site visits at other hospitals to take a look at the telemonitoring. And we have done it, we're now going into our second fiscal year. And the majority of the patients that we use our monitoring for are those low to moderate suicide patients.
Great. Thanks, Melanie. Thanks for introducing yourself. Jamie, go ahead.
Hello, my name is Jamie Clendenin, and I'm the supervisor of nursing operations at Anne Arundel Medical Center. I manage the Telesitter program. I've been with the organization for about 6 years, but recently transitioned into this role in the beginning of this year in 2021.
Great. Ashley.
Hello, I'm Ashley Nursky. I am a clinical nurse specialist at Helen DeVos Children's Hospital in Grand Rapids, Michigan. And my area is acute care pediatrics and behavioral health. And I've worked for Spectrum Health for about 10 years.
Great. Thanks, Ashley. Thank you all for introducing yourselves. So I think getting what a lot of our guests today are going to want to know is what made you decide to develop a telesitting program in the pediatric setting when the devices were brought into your facility. Were they brought in for pediatric use specifically, or did it start out from another program in an adult center that maybe you already had? Let's start with Ashley on this one from Spectrum DeVos Children's Hospital.
So our children's hospital is a part of a larger health system. So we are attached to 2 adult campuses. So when we brought AvaSure in, and we were looking at it from the perspective of both a pediatric and adult video monitoring intervention. So we did a collaborative approach for both patient populations.
And that Ashley was right from the start, right?
Correct. That was from the very beginning. It was the scope was always peds and adults.
Great. Melanie, talk about at Anne Arundel what the decision process was for that.
Similar to Ashley's, when we went live, we did adult and pediatrics, and we rolled out both at the same time.
So you must have had some kind of, as Ashley mentioned, a collaborative team or leadership in pediatrics that were, I guess, frontline thinkers of wanting to use the technology in order to provide safety. When you were developing your program, did you work and have to create separate criteria for pediatric patients, or did you all fall kind of under the policy that was created in general for the monitoring program, specifically about the selection criteria and what that looked like? Melanie, why don't you talk about that first?
Yes, our selection criteria is different from the adults. We use the Ask Screen questionnaire for suicide. And that gives us, it's a 4-question scale. It's validated for pediatric emergency use. And that helps us identify what a level of risk the patient is currently at. So if they're in that low to moderate category, they qualify to have telemonitoring.
And Ashley, I want to ask you the same question I just asked, but before I do that, Melanie and Jamie, can you just clarify, you're using these devices on pediatric patients in both the inpatient and the pediatric emergency department setting, correct?
Yes.
Correct. It's mainly used more in the pediatric emergency room setting for mental health patients, but we do occasionally use it on inpatient for a medical patient, say, that has anorexia or bulimia and needs to be monitored to make sure they're not, hiding food or things like that.
Okay, we'll talk about that in a minute.
Okay.
That's a good segue. Ashley, talk to us about your selection criteria and where you primarily use the telesitting solution for your PEDS patients.
So when we initially rolled out the telesitting, we only had our scope as inpatient medical. So at the time of the project, emergency department was out of scope. So we have primarily used it in our inpatient medical rooms, and our population is a little bit different from adults from the perspective of we use it for our rule out non-accidental trauma patients is one of the populations that we see it frequently used for. So if we have somebody that there's suspected abuse and CPS has not come in to do their assessment, we will put the telemonitoring in. We also use it for our patients who, we use the Columbia Suicide Severity Rating Scale. So any patient who is screened out as moderate risk on that scale, we use it for. And then depending on some of our patients who are admitted for aggression or violence, we will evaluate the patient, and sometimes the AvaSure is a better intervention than actually having somebody sitting at the bedside with the patient. So we, and that's something that actually our adult counterparts are doing as well. So we do have some populations that are adult and peds that we do monitor the same, and then a little bit different based on like our non-accidental trauma population.
Yeah, so not only for the behavioral health scenarios in both areas, but staff safety seems to be a big use. And we've even seen documented staff safety in our database where pediatric patients are placed on video monitoring for aggression and violent and prevention of staff injury. So that's right in line. I want to talk just about a little bit about fall prevention. Both scenarios and both hospitals tend to use the devices, seems like more for behavioral health or accidental trauma patients and patient safety in that realm. Do you ever add telesitting to a patient that might be post-op or might be impulsive from a brain injury or anything like that in order to keep them from getting up without permission or falling? Let's go with Jamie for that.
Yeah, absolutely. We do use the telemonitoring system for that. Traumatic brain injuries, patients, like you said, they're coming out of surgery, impulsive, just waiting for anesthesia to wear off, confusion. I do see it more in the adult population than I do the pediatric one, but we do use that. That I would say that's probably the second, the falls are probably the second highest aside from our pediatric mental health.
Okay, great. Actually, talk about that same question at DeVos.
So we don't routinely use it as a methodology for our fall prevention in pediatrics. The original rollout of the devices was to reduce safety attendant usage, and we wouldn't put a safety attendant in some of those situations, so that was out of scope. So right now we don't include that as a tool for fall prevention, but I know some of the adult clinical nurse specialists are actually looking to expand the scope of using the devices as a tool for fall prevention. So they're working on a project right now, and I'm curious from my perspective what they're going to learn and how we can maybe work towards that in the Children's Hospital.
Yeah, that sounds like a good project to work towards. And A lot of our hospitals start out that way. They start out with sitter cost reduction and really wanting to focus on replacing sitters, but then they see the value and they see the additional benefits of telesitting and how they can benefit patients. And so use cases tend to expand. Speaking of expanding use cases, we had this little pesky thing come up in the last year and a half called COVID. Did you use your telesitting devices at all for any isolation monitoring or ability to communicate with the patients while in isolations, or did you see a big effect of COVID in the pediatric population? Talk a little bit about that. Jamie, let's go with you on that one.
So for the pediatric population, and I'll have Mel also jump in, I don't feel that we used it more to just kind of monitor isolation. Again, I think it was more of the suicide increase that we saw with that population, schools being closed and, you know, home life being different and for everyone. So we saw it more in that realm.
You want to comment on Melanie?
Yeah, I was just going to say I agree with Jamie. You know, COVID did hit us pretty hard and we did see a drop in our census. However, we saw actually an increase in our mental health arrivals. Fiscally, you know, the last 3 years, we were looking at probably 5 to 6% of arrivals being for pediatric mental health. But since COVID, mental health arrivals increased to almost 8% of arrivals. So while total volume was down, the pediatric mental health volume was up.
Ashley, how did that affect you?
Yeah, I would say kind of a similar statement to what Jamie and Melanie have already discussed. I think one thing that we actually used, so we did COVID screening because our psychiatric inpatient facilities in our community would request that patients would have a negative COVID. And so if a patient was coming in mental health crisis, we would swab them. And what we were finding is some of the patients were coming in asymptomatic in mental health crisis. And so we would have to keep them in the hospital until they were able to be cleared by infection prevention. And so with that, AvaSure was really helpful in putting the monitors in the room while we had some patients waiting for clearance until they could go into the inpatient psych facility. So we did end up having a number of patients use it from that perspective. And I know staff felt a lot more comfortable having a set of eyes in the room with the patient versus the Joint Commission said that you could stay outside the room if you had a window. But I think, you know, having that set of eyes in the room to support the patient just made it feel like a safer room environment.
Great, thank you. Let's shift gears a little bit and talk about the actual implementation, the socializing of the idea of video monitoring in a pediatric population. What kinds of different teams were involved in the decisions that you made to bring this in? And I know this is a lot, but I think all of it's important. And how did you get everybody to buy in? Did you have any issues with staff buy-in when you developed the program, or even after the program was live with making sure that you're utilizing it in the right ways? Let's start with Ashley on that one.
Yeah, so when we rolled out the project, it was really as a opportunity to reduce our safety attendant utilization and cost. And I would say the initial group that worked on the project, it was very nursing focused. So we didn't have a very good multidisciplinary team when we rolled out AvaSure to really talk about all of the scenarios that we could use it, really help providers and other staff members understand, particularly like our social work team and our care management team, understand what the purpose behind doing an AvaSure versus a safety attendant. And so I think when we rolled it out, we did not do a very thorough job of communicating it to people outside of nursing. And so that was one of our challenges, particularly with like the non-accidental trauma patients. Providers were really adamant, like we need somebody in the room, we need them to be watched. So just a lot of in the moment conversations and rounding with the provider team to really talk them through what this new technology is, the benefit of it, and why we're using it. So I would say in hindsight, it was a little slow rolling with getting buy-in, particularly from some of those provider and ancillary departments, because we didn't engage them initially in the conversation. I think now that we've had such a high volume of our patients coming in mental health crisis and a lot of patients coming in with aggressive behavior, they've seen the benefits firsthand of what this technology can do and how it can still support the patient and the safety of the patient, but also doesn't need to have a physical body at that patient's bedside all the time. So
Sure.
I think just the sheer volume of people that we've seen in the last year that have had a positive impact of the AvaSure has
Great.
kind of spoken for itself.
Great. Jamie, same question. How do you deal with buy-in issues or other members of the teams that have questions about the operations and about the program itself?
Yeah, absolutely. So of course, whenever you roll something new out, there's hesitancy, especially as Ashley mentioned, staff is so used to having that one-on-one person there with the patient. They're wondering, well, if they're going to get involved, how are we going to manage this? So I think one, having the buy-in from the leaders. I know there were some site visits when we rolled this out, and I think Melanie was part of that. So we had, leaders that were involved in the decision making, and I think that helped. And so having a strong leadership connection right out of the rollout helped. Additionally, I think now that it took a little while, we rolled ours out in October of 2019, and it took a little bit of time, a couple months, but now that staff sees the benefits of this, not only that it helps keep the patient safer, it also allows direct patient care staff, like patient care technicians, to stay at the bedside. So, we're keeping the people that need to be at the bedside, because if we need a sitter and we don't have one, we would often pull our patient care techs. So I think just the more that we did it and the more they saw the benefit and the more they could keep their frontline staff at the bedside really helped the buy-in.
Yeah, those are really good comments, Jamie. Thank you. We're talking a little bit about all of the benefits and all of the things that the telesitting program can do to help keep your pediatric patients safe. I believe I was a bit remiss at the beginning of asking you for details on how it actually works. When a patient does look like they're going to be involved with an adverse event or get out of bed and put themselves in a risky situation, what actually happens with your program? What do you tell your monitor staff, Jamie, to do, and how do they intervene with that patient? And how do they prevent an adverse event or a fall?
Absolutely. So every time a new patient is put on the monitoring system, they get a report from the nurse, and it has to be a nurse that puts them on. So a lot of times the nurse will give them expectations, like it's okay if the patient does this. However, if they do this, I want you to call me. So sometimes that communication is great. Once a patient is in the act of almost falling or their legs are becoming on the side of the bed, we have a few things. The monitoring staff can, one, redirect the patient. They can speak to the patient can hear them, and they can say, please put your legs back in bed, or do you need something? I'll get your nurse, hang tight. And sometimes patients are responsive to that. If they're not, they can call the nurse. The nurse's information is right on the patient screen, so you can see the patient and all of the clinical staff information that you need, so they can quickly call the nurse. And then if it's one of those situations where you don't have time to call, you don't have time to react with those conversations, there's a stat alarm button, and you press that start alarm button. It's loud, and the staff come running, almost as if I could compare it to like a code. If you hear a code, everyone comes running. You hear the stat alarm, everyone comes running.
Okay, great. Thank you for that explanation. Just a couple of questions that I'm seeing that are coming in that we might as well address right now while we're on that topic is, what if the patient can be mobile in their room? How does the camera still see that? And then also, when you're using these devices for patients that are moderate to low risk suicide ideation, do you have to have a sitter in the room with them as well?
So as far as the cameras are 360 view. So the monitoring tech can actually click on the screen wherever they want to see. So if the patient's walking, that's something that the nurse will communicate. It's okay if the patient walks, especially in the pediatric, Children are not expected to stay in their bed at all times. They need to be, you know, up and moving around. So the monitoring tech can follow them around the room, and the monitoring screen itself is pretty large, so you don't have to move it every time they take a step. You can get a pretty good view of the room if you position the camera appropriately. So that really helps. And then I think that the other piece is the nurses, if they call and they need something, the monitoring tech is really good about saying, hey, this is what's going on. I need you in there now.
Nice.
There was another question you were asking. I think I didn't answer it all.
Oh, I was asking if you ever use a one-to-one sitter simultaneously with a device.
We do not. We do not. So if they are suicide, we still take our hospital policy suicide precautions, such as taking things out of the room that they shouldn't have, cords and safety concerns that way, environmental safety. But we do not have an in-person sitter as well. That monitoring sitter is all that we need.
Great.
If
How
there's
about you, Ashley? Oh, go ahead, Melanie. I'm sorry.
No, I was just going to say, like, if there's frequent hitting the stat alarm, you know, generally our rule is 3 in 1 hour, then we need to reevaluate if they're really a safe candidate for telemonitoring. But I would say that happens very seldom on our unit that we have to switch.
Ashley, what about you? Do you ever use one-to-one sitters simultaneously with telesitting?
We have had it at a very rare occasion, and it's particularly with patients who have maybe sexually acting out behaviors where we have a level of concern that we need somebody in the room, but with like a second set of eyes anytime the staff has to engage with the patient. So very, very rarely have we had to do that, but it is a nice option for certain situations. And for the patients who walk around, we've created a boundary in the room that we communicate with the monitor tech and with the patient, that if they get to this point of the room, they can walk around until here, and if they're here, they need to be redirected because they're getting close to the door. And we've found that the monitor techs appreciate that visual boundary, so they know, like, okay, the patient's fine on this side of the room and that's a safe area, but once they start getting over to that edge, they're getting close to the door, and are able to intervene quickly, either with redirection or with calling a nurse. So that's been a helpful thing. And we also do the similar thing that Jamie had mentioned with the rooms. We take everything out of the room that is unsafe per our policy, and so they are in secure room environment with the monitoring, but don't need a safety attendant.
Great. Wow, those are some really good tips for good communication between the bedside staff and the monitoring staff, and that's really important. Melanie, start out a conversation about training, and I want to hear from Jamie on this too, and Ashley, but there's a couple of different aspects of training that might be different in the pediatric population, as far as, number one, training the monitor staff for different needs of pediatric patients. So was there any additional training done? And then training the staff on how to talk to and educate the peds patients and their families about the devices in the room. So talk about those two, training the monitor staff and then training the bedside staff for patient education.
Sure. So I'll start with training the bedside staff for patient education. We have what we call mental health welcome bags. So when a patient arrives for mental health complaint, they get a welcome bag, and included in that welcome bag is the AvaSure quick reference guide. So it's a good kind of one pager that the staff goes over with the parent and the patient. And really kind of, I think the biggest thing for us is to stress that it's not a recording, that it's a live feed, because that tends to be like one of the most questions that parents ask about, like, where's the recording going to? And it's not. And they also like hearing about the privacy feature as well. And so really, we've had really, I mean, our parents tend to really love it. We have some really great senior sitters that monitor the patients that have given their picture. And so when they're behind the camera, we hang the picture on the camera, and it's them smiling, saying, my name is Brooks, I'm here to keep you safe. And the patients, especially pediatric patients, because they generally have a lot of questions, really seem to like that. So it's kind of like the face behind the camera.
Anything to add to that, Jamie, or any special training for the monitor staff that's occurred?
So the monitoring staff, when they're hired, they come in and do an orientation with me, and we go over specific suicide precautions, mental health precautions, things like that. And then as far as the pediatric population, Melanie and her team created a pediatric tip sheet that all new staff members are given and gone over and kind of given a lot of guidance on how to interact and engage with pediatric patients.
Very nice. Ashley, how about you? What have you done in those two scenarios?
Yeah, so we used a similar kind of education sheet to provide families to help make sure that we're kind of addressing all of the highlights of the video monitoring, and staff review that before going in. And I think, yeah, the biggest question is recording versus not recording, and just, you know, reinforcing that this is not being recorded, and also that they're not being listened to, I think is another big thing that we reinforce, that they don't keep, you know, the monitor tech doesn't keep the sound speaker on. They only will engage it when they need to, you know, talk. So that was one of kind of the two things that families asked most about. But for the most part, they appreciate not having somebody sit there right at the bedside staring at them. So they are more receptive to having actually the video monitor or the AvaSure device in the room versus a physical body in the room. And then for our video monitoring techs, what we have done is they go through kind of our general orientation, but our pediatric nurse educators have created a self-learning module that talks about just the different developmental levels of children and how to engage with them. And then they do kind of some clinical scenarios. So they've created a couple of different situations, and they actually recorded they got very creative with it. So it's actually a video of like what the video monitoring tech would see through a room, and kind of like maybe opportunities to redirect a family member or a patient and how they would go about doing that. So they did a lot with trying to really highlight the different communication needs of children across the lifespan.
Very cool. Neat. Well, we might be contacting you all to get some other ideas on that. Great. I have just a couple of questions left that I want to ask the panel, and then we're going to open the floor up. I think one of the big questions, especially after we've discussed that the majority of the population is behavioral health reasons and the low to moderate risk suicide ideation pediatric patients. Talk a little bit about regulatory bodies. Have you had surveys from your regulatory agency during the time you've been using telesitting? If yes, any comments? And if no, do you anticipate any issues, or have you had conversations about that? Let's start with Melanie on that one.
Yes, so we haven't actually had a site visit where we were live with the telemonitoring, but it is very much a topic. You know, we have Joint Commission readiness every month, and so we're constantly making sure that we're meeting criteria, and that we, you know, are showing that we've done our assessment that determines that they are eligible for that low to moderate risk of telemonitoring. So it definitely, you know, also supports the ligature risk that you worry about, because a pediatric emergency room is not a mental health unit. And so there is different ligature risks, which the telemonitoring does help monitor.
Are the only criteria that you use that are based on regulations from, I think you said your regulatory body is the Joint Commission, is the questionnaire or the risk stratification tool? Or do you also have to look at what your policy says you're doing, and also because it's non-recording and things like that? What all plays into the idea that that this is going to be fine when there's a survey that's occurring?
Yeah, it definitely has to follow the policy. So the policy speaks to suicide, homicide, mental health concerns, and the screening tools, excuse me, are rolled into that policy, and the frequency of the screening tools, and kind of a graph of when a patient falls in this criteria, then what needs to happen to follow policy to ensure their safety. So definitely we're reviewing policies frequently and making sure that our education and our criteria all matches the policy and the education that we're giving to our families.
Yeah, and that also goes with the documentation.
Go ahead,
sorry, that also goes with the documentation. So our they have documentation that they have to complete. So that goes right in the medical record. So that piece is also part of the policy and Joint Commission.
Right. Oh, that's a really good point. The documentation that goes in the medical record is done by the monitor staff, or is it done by the nursing staff, or both?
No, both. Both have documentation that they have to do, but the monitoring staff for a behavioral health patient has to document every 15 minutes. They're pediatric, so it's every 15 minutes. They have a computer they can use, but most often they use a piece of paper. They find it easier to jot things down on a piece of paper since they're already watching a monitor. And they're able to put in certain codes and numbers. There's a little key that says what the patient's doing every 15 minutes, what they're, are they calm, cooperative, aggressive, things like that. So you have lots of things you can chart there. And then at the end of every shift, they have that scanned into the medical record.
Ah, okay, great. Ashley, how do you deal with the regulatory bodies at DeVos?
So we have not had a survey. We actually, our window is July 1st. So we are in preparation, mode right now. But really our policies really support when we can use it and when we can't. So we basically aligned with what Dr. Posner, the author of the Columbia Suicide Severity Rating Scale, recommended her interventions to be. So we really aligned with the evidence that she has published to indicate when video monitoring is appropriate, at what risk level, and when it's not. And then we have it spelled out in all of our policies that anybody who is screened out as high risk for suicide has to have a safety attendant, a physical person, and then also for violent restraints, we have a physical person. And then basically as a health system, we've left it open to the clinical decision making of the team to really have that collaborative, multidisciplinary conversation about, do we think this is the right intervention? Do we not? And how can we maybe have that more collaborative conversation? And I think that has also helped with our buy-in and really learning more because we didn't put very much structure around these situations you can't use it, these situations you can. We kind of left it up to the clinical decision of the people at the bedside. Okay. And that's how we have it designed in our policy as well.
Great. All right, thank you for that. Let's talk a little bit about what, we're all in this to keep patients safe. And our mission is helping people keep patients safe. Let's talk a little bit about the money aspect of this. How is telesitting benefiting your hospital or your pediatric areas from a cost or a return on investment perspective? Do you track that? Is it easy or difficult to track? And what are you seeing? I'll start with Melanie on that one.
So this is one of the things I'm most excited about because we have saved a lot of money. So just for example, this fiscal year, so starting July 1, we've used telemonitoring 11,113 hours. So if you take that times the average sitter makes about $19.10 an hour, that's really a cost avoidance of $212,000, 500 and some change. So that is huge because that amount of money allows us to purchase other items that we need to care for our patients. And so it's really been a huge cost saving for us. It's works. It keeps our patients safe. Knock on wood, we haven't had any adverse reactions with the patient being on a monitor. So it's really been beneficial for our pediatric population.
Have you noticed that even with the cost avoidance, that there's still a reduction in the number of sitters that you're actually using? You're not just using sitters plus telesitting, you've actually been able to reduce the number of sitters?
Yes, because our population of usage with telemonitoring is about 60% of our mental health patients need or qualify or are candidates for the telesitting. So it's really been beneficial to us and kind of kicking it back to getting staff buy-in, as Jamie said before, like stressing that they're getting their resource back of now the tech is free to be a tech and not be a sitter. And so it's really just about giving resources back to the team. And celebrating small successes, even 1 month with no adverse events and good catches, things like that.
Great. All right. We're going to transition. We've been talking for 40 minutes already. It doesn't seem like that because it's so much fun to talk about this. And I'm back in my old pediatric world and I love it. We're going to transition to some questions. We've got some rolling in. I'm going to go through some of the questions. While I'm going through and deciding kind of what order I want to ask and things like that, would each of you share one of your favorite good catch stories with us, or a story about how monitoring helped avoid an event, or what you were able to keep from happening with monitoring? Jamie, let's start with you on that.
Sure, absolutely. This one actually happened fairly recently. I go in and check on the monitoring staff often, and I just happened to walk in, and they were literally in the middle of, they were monitoring a patient. The patient looked like he was going to ingest something. They weren't sure, and so they called the nurse and called the tech as well. They said, something doesn't look right. I can't see exactly what's happening. Something doesn't look right. And just in that minute, the patient had something and put it in their mouth. And the nurse was able to walk in right in there and right in that moment and prevent something from adverse happening to that patient. So it was a great communication. Everyone worked quickly, and it just happened so quickly. It just happened to be when I walked in, and it was just in a matter of a minute.
Great. Melanie, do you have one?
I do. I actually have a few. So even just last week, so we give our patients safety trays, which means, no aluminum cans or utensils, things like that. And so when the trays get delivered, it's nice because the telemonitor has the ability to zoom in to ensure that their tray has the safety items. And actually twice last week, the telemonitor was able to pick up that the patient was given a plastic fork instead of a paper spoon. And so they were able to call the nurse and get the, supplies or utensils moved out of the room, which was a really good one. We also had an event where a patient had been evaluated and had been told that they were going to go to inpatient facility. They had already been there before and they were not happy about it. And so they ran into the bathroom to drown themselves in the sink. So the telemonitor hit the stat alarm, staff was able to get in there and actually initiated a practice change for us because we now removed the locks off of our bathroom doors.
Wow.
So it was, yeah, and it was immediate that, when we hear that stat alarm, everybody jumps in. So it was really beneficial.
Have you been able to measure your stat alarm response time? Do you know what that is?
So I looked at that and I could tell you, but I don't remember exactly, but it was low. It was very low. Sarah and I worked on that. It's a matter of seconds.
Matter of seconds. Okay. Ashley, do you have a good catch story?
Yeah, we had one of our patients who was an elopement risk, and the monitor tech, they had been watching the patient for a number of days, so definitely got to understand their patterns of behavior and had noticed that the patient was pacing a little bit more, but also kind of rifling. We don't let them have belongings in the room, but had started rifling through cupboards and stuff, like looking for things. And so called the nurse, and just as the tech was calling the nurse, the patient was making a beeline for the door, and we were able to intercept the patient and redirect and provide some additional support so they weren't able to get out onto the unit or off the floor. So just, that quick thought process of the same thing, something's different. and you need to, act quickly. So it did, yeah, they definitely pick up on a lot of stuff in those rooms.
I bet. And there's so many stories that can be told too about the keeping patients safe and the benefits. We've got a lot of really good questions that have come in. Thank you everybody for typing your questions into the chat box. They're really fun questions. So a couple of them are asking about what's going on in the monitor station area. So I think, Jamie, I'm going to ask this for you. What is number one, what is the ratio of monitor techs to patients? Do you have a maximum ratio? And while you're talking about that, if you could clarify, are your monitor techs monitoring pediatric patients only, or are they monitoring a combination of pediatric and adult patients on the same screen, and how does that work?
Sure, absolutely. So currently our monitoring station, there's one monitoring tech to 12 patients. AvaSure does say we can go up to 16, but our hospital has decided we're going to shoot for 12. The monitoring tech will monitor pediatric and adult patients at the same time. I will tell you, however, they get a system to their workflow, and many of them, if they're watching adult and pediatric, they may put the adult on the top of the screen. It's a very large monitor. So they may have the adults at the top, the pediatrics on the bottom, but they try to keep them as close together and organized as possible. They are in there by themselves, so there's no distractions. We have people go in there and relieve them, give them breaks, lunch breaks, things like that. And we also, because they work 12-hour shifts, what we usually have is we have two telesitter monitors on at one shift, and we swap them halfway through the shift. So someone might be there in the morning, have lunch, and then after lunch, they may sit as an in-person sitter for the afternoon, and then vice versa, because sometimes looking at the monitor all day can become overwhelming.
Sure. Ashley, are there ever any scenarios that you're aware of where patients have a telesitter placed, but you've learned that they're not suitable for telesitting? What does that process look like? Is there a failure criteria? And what is the exclusion criteria you typically see? I wouldn't think that telesitting can be used on every single patient. It depends a lot on the behavior. So talk a little bit about that.
Yeah. So one of the challenges is the number of redirections a patient may need. And for some of the younger children, having them in a room, it is challenging because they need a little more supervision to help guide them through a day. So what we found is that the younger population, particularly like 10 and under, need a little too much redirection during a day to really be safe for them to be on AvaSure, because it takes, the monitor tech is constantly having to, you can't, jump on the bed, or you can't, you're getting close to your boundary, you need to, get back on the bed, some of that. So then it becomes, unsafe for the other patients they're monitoring. So we look at the number of redirections a patient might need. And also, we don't put an age limit on it, but we found that under 10 becomes a little more challenging. And at night, though, what we've done is, yes, they may need somebody in person during the day, but they sleep well at night. We can get them, down at night. So often what we'll do with some of our patients is start AvaSure at 7 p.m. and do 7 p.m. to 7 a.m. And then they have somebody in there during the day. So a lot of it depends on just the behavior of the patient. And sometimes we take a day to kind of understand what their level of aggression is, or their ability to be redirected, and then put them on, because we're more successful if we understand the behaviors a little bit better.
Sure. Yeah, no, that makes a lot of sense. There's a couple of other questions about the monitor techs. Melanie or Jamie or Ashley can answer this, but when you first started, did you find that the transition was slow, that you had to have sitters in the room for a while? Or did you start out right away just putting telesitting in the rooms in order to get that immediate benefit from the burden of having the staff sitters? Melanie, I'll go ahead and ask you that one.
Yeah, when we went live, we went immediately to the telemonitors.
Okay. How about you, Ashley? Did you go immediately to the telemonitors?
Yes, yep.
And Jamie, when you're hiring for the position of monitor tech, what do you look for in the experience of a that would make a good monitor tech for this role?
So the role is an entry-level position. They don't have to have a specific license. However, I do think that being organized and being able to really focus on a task is important. So I kind of look for someone that maybe has some type of, even if it's a customer service role or some type of assistant role, something that they've done where they've really kept things tidy and organized. It's also important that they're great communicators. Because not only are they communicating with the nursing staff, but they're the first communication with the patient. So they need to be, able to engage, and they need to be have charisma. Sometimes it's just a matter of how they're speaking to someone. So some of those things are very important when I look for the monitoring techs.
Great. A little while ago, we had mentioned that there was some use on the inpatient units for patients with eating disorders. Talk a little bit about that and how maybe Ashley and Melanie, talk a little bit about how you've seen this use case save you a lot of costly staff, and has it been effective with the patients? Go ahead, Melanie.
Yes. Yeah, so we do, use it mainly on the inpatient side if we have a patient with eating disorder or that non-accidental trauma patient where we need to monitor the family members with the patient. But it's worked really well. Oftentimes, I think the patients forget that the monitoring system is in the room, and so they really are their normal behavior. And so, it's helpful because it's kind of almost like a secret eye to make sure the patient is staying safe and not hiding food, or not fully stepping on the scale or stepping on the scale excessively, things like that. So it's been really beneficial for us. We mainly use it for peds mental health, but it's definitely helped us on our inpatient side.
Great. Ashley, same question. What have you?
Yeah, we've, I would say this population was maybe one of the slower ones to transition, particularly because I think people were just so used to having a physical person in the room. But I agree, I think that the families and the patients appreciate the monitor versus an actual person sitting there watching them. And the one thing that we've really had to focus on is really good communication with the monitor techs, particularly in the guidelines of what we want the patient to do or not to do. So we really have coached the nursing staff to give a very detailed report to the monitor techs. So yes, the patient can get up out of bed and sit in the chair, but the patient cannot pace the room or cannot start walking laps, or if you see them excessively shaking their legs or moving their hands, to try and redirect the behavior, because we don't want them, potentially exerting extra energy. So this population was probably one of the last to really embrace the technology with, but now that we've really worked through some of the I think the communication stuff has been the key. Families are much more receptive to that being in the room versus a physical person.
Yeah, and just to mention, this has been something that we've seen in our data increasing a lot too, with the comfort of the use of telesitting on pediatric patients. This use case is getting some attention. There is some resources out there for those that are interested, in particular, one in the Journal of Hospital Medicine published in 2019 by some researchers at University of Wisconsin. And it's a retrospective cohort study that compared the cost difference and the outcome difference if a nursing assistant was sitting with eating disorder patients as a one-to-one, or if there was continuous video monitoring with one-to-one. So that will be a good article for you to reference. There was, of course, a big cost difference. There was no difference in length of stay, or there was no weight gain in the patients that were under this study. And there was no occurrences of family refusal. So that's good. In this article, there is some information about the cost of telesitting, specifically the AvaSure telesitting program, that is inaccurate. So they are working on republishing that or publishing a correction statement. But for those of you listening, if you do read that article, that cost is inaccurate, but you can check with us on anything else. All right, I have to end with my favorite question all the time that I have to ask is, what are the fun things that you've done with these monitoring systems, or with this monitoring system for the kids? I mean, are they scared? Do they like it? Somebody mentioned, I think it was you, Melanie, that they don't really even notice it's in the room, but do the monitor techs have fun with them?
Yeah, I think that some of the monitor techs are really fun, and they'll, tell them jokes, or, try to engage with them as much as possible. I think it's also fun, like at Halloween, that you can dress up your telemonitor.
Oh.
Or if having a luau, you can put a lei around the monitor. So I think, we get creative and include everything in the room when we're celebrating something. But I think kids like that.
How about you, Ashley? Have you seen that?
No, but I think that's a great idea. I'll have to mention it to our child life team, because they definitely like to have themed celebrations. But yeah, I think same thing, like especially patients who may have longer admissions, the monitor techs get to know them and will, have some conversations and play around with them. So yeah, just building that relationship, even though it's a distant one, is a positive one. So yes.
Great. Well, Melanie and Jamie and Ashley, thank you all so much.
Thank you.
We have a lot of requests on the questions for sharing some of the resources that you mentioned, some of the checklists. Jamie, you mentioned there was that your hospital uses a different severity risk assessment tool than the Columbia. Was it called the ASK?
Yes.
It is. Yeah, it's the ASK screening suicide questionnaire.
Yeah. Okay, so we might be emailing you for some of those resources. So check and see if you're able to share them with us, and then we can distribute those as appropriate.
Okay.
Thank you. I have a couple of announcements before we close, and I think we're going to get some slides pulled up here just a second. But thank you all so much for your input and your conversation regarding keeping our pediatric patients safe with video monitoring. From AvaSure, we do have one of our famous and fun symposiums coming up again this year. It is going to be virtual again this year. We did this last year and it was really successful. So mark your calendars for October 6th and 7th. There will be a virtual symposium. You're still going to be able to do breakout sessions. It's going to be full of learning, collaboration, and networking. And it's available for both current and prospective customer partners. So more details to come on that. Also, if you're a current customer, nominate your hospital or an outstanding monitor staff member for an AVA prize. The AVA prizes are fun. They're our healthcare awards program, and they honor individuals and organizations that have advanced patient and staff safety and that have really worked to innovate their safety methods in their hospitals. So visit the event section on the website for more details on the AvaSure website, and you can nominate either a monitor tech or a program for an AVA prize. That concludes the webinar today. Thank you all for joining. Again, as a reminder, we will be sending out a recording and any of the resources that we can get our hands on. Thank you to our panelists. You all did a great job. Thanks so much. Have a great day, everyone.
Bye-bye.
Bye-bye.
Thank you.
Aye.